Good evening, everyone. It's Sunday, September 25th, and I'm Debbie Hilbasell, and tonight we're going to do another one of our expanded case list review nights, or case list defense, whichever you want to call it. So we'll be going from 8:30 Eastern until 10 p.m. I know earlier today, Lou Foley did a makeup case list defense webinar. So if any of you guys also did that, you're getting two and six, well, yeah, what would that be? 3 hours worth of case list review. So anyway, you're probably going to be sick of it by the end of the day, but practice, practice, practice. And it's always good to hear other candidates, even if you're not volunteering, just hearing how the questions are asked, how people are answering. And also, even if you don't volunteer, you can think in your head, how would you answer it? So all of it is a good learning experience. We've already got 34 people signed on tonight, and they keep signing on, so we've got a nice crowd tonight. Again, how to participate, you guys got this. You've got the little orange arrow that opens and closes your panel. You can everybody's on mic and speaker, so we don't really even have to worry about how you call in on the telephone. And of course, you guys know that in order to volunteer, you raise your hands. Again, I'm just going to ask when we get to the point, I'll ask, those who haven't gone yet who want to please raise your hand, etc. And we just want to make sure that no one is upset that they've been wanting to be called on and they haven't been able to be called on. And then when I will unmute you on my end, I'll unmute the little microphone here, and then you just have to make sure you're unmuted on your end. Again, every time I do the little case list defense, I like to start off with just a little quick, piece of information or pearl or something that's new. So tonight I just wanted to briefly touch on mycoplasma, only because we finally have a NATS test available where we can actually detect it. Prior to that, mycoplasma, we can only do cultures, and it can take up to 6 months to get the result of the culture because mycoplasma is an incredibly slow growing organism. So really it was only used in the research setting. So now that we have this ability to test for mycoplasma genitalium, like when are we supposed to, how are we supposed to, how do we treat it, etc. So let's just look. This is right from the CDC guidelines. So mycoplasma genitalium is associated with cervicitis, PID, preterm delivery, spontaneous abortion, and infertility. And they, if you have mycoplasma, having any one of those outcomes that I just discussed, you have a twofold increased risk of having that versus if you weren't infected with mycoplasma. So in women who have cervicitis, especially recurrent cervicitis where you've not been able to come up with the etiology, you really should screen for mycoplasma. It is detected in about 10 to 30% of cervicitis. Now, when they look at women with PID, the prevalence, in addition to the whatever other bacteria you've cultured for or done NATS testing on, the prevalence can actually range anywhere from 4% to 22%. The problem is with some of this, if we just tested all asymptomatic women for the presence of mycoplasma, the percentage of times it's been there, they haven't really said, but oftentimes people are infected and it's totally asymptomatic. And the consequences of an asymptomatic infection at this point in time is unknown. And who knows, it may change. With chlamydia, you can have an asymptomatic infection, but we screen for it now because we know you can get, quote, silent PID. But at this point in time, we're not sure the consequences of asymptomatic mycoplasma. In the past, we used to treat it with azithromycin, but just like with so many things with the macrolides, same thing with mycoplasma, the resistance to azithromycin is rapidly increasing. So the NATS testing that we currently have available is cleared by the FDA for testing urine samples, for doing urethral penile meatus sampling, to do endocervical sampling as well as vaginal swabs. So women with recurrent cervicitis should be tested for mycoplasma. You should consider it in women who have PID. You should not screen asymptomatic women. All right, so a little bit about mycoplasma. It doesn't have a cell wall, and thus antibiotics that target cell wall synthesis are ineffective. So the penicillin, the beta-lactams, the penicillin, cephalosporins, etc. We already talked about there's a very high rate of macrolide resistance, so azithromycin is not effective. In some other countries, the UK, etc., they can actually, when they test for mycoplasma, they can actually test for macrolide resistance. And if it's not resistant to macrolide, then they do doxy plus azithromycin, but that's currently not available in the United States. So if we get a positive mycoplasma genitalium on our NATS testing, we are supposed to treat with doxycycline, 100 milligrams BID for 7 days, followed by moxifloxacillin, 400 milligrams a day for 7 days. They don't take it at the same time. It's basically 14 days of therapy with one antibiotic first, followed by the second one. The current PID regimens that we prescribe for our patients, the ceftriaxone, doxycycline, and metronidazole are not effective against mycoplasma. So if you did test a patient with PID also and for mycoplasma and it came back positive, you do moxifloxacillin for 14 days, the 400 milligrams daily. However, we still have no data to say should we test for it in women with PID. Test of cure is not recommended for patients who are currently asymptomatic and received recommended treatment. So like right now, if you had trichomonas, chlamydia, gonorrhea, we treat it. We're going to test for reinfection in 3 months. We don't do a test of cure unless they're pregnant. And at this point in time, they don't even talk about test for reinfection and do not recommend doing a test of cure if the patients have been treated and then they're currently asymptomatic. What about the sex partners? Well, they said recent studies show a high concordance of mycoplasma among sex partners. However, we don't have any studies to show if treatment of the partner reduces the reinfection rate. You can consider testing sex partners, and if they're positive, if the test is positive, you can treat them and it may possibly reduce the risk of reinfection. So it's a whole bunch of we don't have this, we don't have that, but because that new testing is available, and I don't know, maybe it could come up, it is something new. I just wanted you guys to be aware of what the current information and data that we have. Okay, so now I'm going to be looking for volunteers, and I'm going to start the same way I did last time. And that's basically going to be, is there anyone who let's get out of here. Is there anyone who has not been called on in the month of September and they really want to be called on? So I want to make sure we get to those people first. So please raise your hand. So whoops, hang on here, somebody. So Rit, have you not been called on? Oops, now you disappeared. All right. All right, so I guess everybody who's wanted to go has go. So let's start for round 2. So anybody who would just like to go, let's do it. All right, let me just start up here. Let's start with Bianca. Hey, Bianca, you're just muted on your end.
Can you hear me?
I can hear you now. How are you?
Good, how are you?
I'm just great. Now you know about mycoplasma.
Thank you.
You are welcome. Are you a generalist?
Yes.
Okay, all right, good. So do you have a particular case list you'd like to do? Or even a particular case? And that's the other thing, you guys, before I even call on you, if you go, oh my gosh, I have this one case I am just so worried about. I just really want to run it past the examiner and see how they would, how I can defend it better, etc. Feel free to use this time to use that to your advantage. But anyway, so for you, Bianca.
No, any list is fine. There's plenty of things on all of them.
Okay, well, let's just start with number one. Let's start with your GYN.
Oh, sorry,
And,
me.
huh?
That's
That's not you, is it? How did I hit the wrong one? I did hit the wrong one. Okay, yep, I hit one down below.
no problem.
All righty, gotcha.
Okay.
Mhm. Let me kind of go to the back because we always tend to look at the front and grab something. So let's see here. This isn't a really tough one, but I think it's a good review for everybody. Let's look at patient 41.
40.
Yeah, she's 45 G6P4 and her pap comes back HSIL positive, HPV 16 positive. So you're like, okay, I'm doing a colposcopy on her. The
Right.
colposcopic biopsies come back SYN3 and the ECC is benign. You chose to do a leap. Did you give any thought to doing a cold knife cone on her? And tell me why you chose to do a leap versus a cold knife cone.
Yes. So if her ECC had been positive, then I would have considered doing a cold knife cone over a leap. But I do leaps more frequently. So I felt comfortable doing that. I also offered her both options, and after shared decision making, we opted to proceed with the leap.
All right, if she had been 25 G0P0, tell me why the leap would be preferable.
So, especially with her being so young, if she was 25 and nulliparous, then a leap I could potentially take less of the cervix so that she'd be at a decreased risk of complications with pregnancy in the future.
Okay,
And
now, go ahead.
I was going to say, and then cauterizing the margins and the base.
Okay, so in this case, your the SYN3 extended to the cauterized ectocervical edge. So I guess we could call that a positive ectocervical margin. What's the significance of that? What is the preferred follow-up?
So with a positive margin, the preferred follow-up is to perform a colposcopy at, either I could have re-excised, but the preferred method is to do a colposcopy at 6 months with an ECC as well, and then repeat that at 6 months after that as well.
And especially with a leap, what's the significance of a cauterized edge being positive?
So because the edge is cauterized, it's difficult for pathology to see if it's a true negative margin or not. The other thing is that because I cauterized the base of the leap, I could have cauterized the abnormal tissue and might have treated it anyway.
When would you absolutely do a cold knife cone?
In general,
Just in general.
um, I guess it would depend on multiple factors, but if the ECC on my colposcopy was positive and the patient had completed childbearing.
Okay. What about if, like ECC positive for what?
Um, for a high-grade lesion.
Okay. What if it was adenocarcinoma in situ?
Then yes, that as well.
What if the colposcopic biopsy showed carcinoma in situ cannot rule out microinvasion?
then I would also do a cold knife cone for tissue diagnosis, but also consider sending to oncology.
Okay. If this patient actually maybe her pap was HSIL and it was positive HPV 18, you got back SYN3 and the ECC shows AIS. So you do a cold knife cone and it comes back SYN3 margins free and AIS with negative margins. Well, how are you going to manage this 45-year-old?
Because AIS has a high likelihood of skip lesions, I would counsel her about her options that we could continue to survey and perform colposcopies and PAPs closely. However, given she had such a high grade lesion, I would also consider offering her a hysterectomy.
Um, would you, how could you even justify maybe in a 45-year-old just following AIS? What is the recommendation?
I would have to look up the exact recommendation, but since AIS has, I believe it's to perform a hysterectomy because there is the high likelihood of skip lesions and a risk of concurrent carcinoma. So
Yeah,
I would recommend.
so yeah, so for AIS, the thing that's different about AIS than even CIS, number one, it's up in the endocervical canal. So it's pretty darn hard for
Mhm.
us to be able to visualize with colposcopy and just depend on blind ECCs, you know what I'm saying, to really evaluate what's there. And then the other thing is that AIS can be multifocal, it can have skip lesions. And so even if we get negative margins, doesn't mean that there's not AIS just above it and it's going to develop into adenocarcinoma. And so truthfully, AIS, the treatment is hysterectomy. The only time you would drag your feet would be if she was a 25 G0 P0. Well, then we want her to be able to have fertility. But truthfully, if I had a patient like that, I would send them to GYN oncology and let them follow her. And oftentimes when she's done with childbearing, they still recommend a hysterectomy. So AIS is that weird one there that we just have to be more aggressive on.
Okay.
But so for you guys, all the ASCCP guidelines can make your head absolutely spin with all the different things it can do. But anyone that you have chosen to put on your case list, regardless if it's the GYN case list or your office case list, make sure you know for that patient not only what her initial PAP and what your treatment was, like LEEP, etc. But now that you've got someone like this, then know what's the acceptable, like preferred follow-up, acceptable follow-up, how frequently you need to do the PAPs, and when can you go back to routine PAP screening. Now, this patient's 45 with SYN3, so how long is she, if every single PAP from here out, Bianca, is normal, how long does she have to go before she can stop PAP smears?
25 years.
Yep. So she's going to have to wait till she's 70, right? And that's with her doing all of the proper screening.
Right.
Okay. All right. Good. All right. Any other questions?
No, I don't think so.
Okie dokie. All right. Thanks.
Do you think my
Whoops. I'm back. I'm back.
Sorry. Do you think my answer for leap versus cold knife cone is acceptable? I also
Yeah.
just do more frequently.
Yeah. Well, you can say that you do it more frequently, but the other thing with this too is that it because the ECC was negative, her disease is on the ectocervix. You can see where you need to go. You're removing less tissue. There's less chance of bleeding. There's less chance of post-op bleeding. People coming back. It's an easier procedure. You're damaging less tissue, and there's less post-op complications. I would bring that up also.
Okay. Thank you very much.
You are welcome. Angie, I'm trying to, let's see. How you doing?
I'm great. How are you?
I'm doing fine. Let me find. Are you a generalist?
I'm not. GYN oncology.
All righty. So oh, and you don't even have a OB case.
I
Let's
only get it 3 weeks before my date, so
see.
unfortunately. So I
All
mean,
right. Let me pull office and see if I can find something that I can kind of do. All right. I can do, yeah, let's do patient. Well, let me just look here. Let's do okay, let's do patient number 5. So you have did you know she had endometriosis or was this a suspected?
this was suspected.
Okay, so 35-year-old comes in to see you with chronic pelvic pain and dyspareunia. And then I'm going to make the history here that after you take her history, then you're thinking, I'm wondering if the etiology of her chronic pelvic pain is endometriosis. But when she first comes in to you telling you about this chronic pelvic pain she has, as well as dyspareunia, I want you to walk through the your differential diagnosis for me.
Okay, I consider gynecologic and non-gynecologic causes, and I first start sort of top to bottom. So neurologic conditions, things like neuropathic pain. You have psychiatric conditions, so depression, post-traumatic stress disorder. Let's say that's then musculoskeletal things like fibromyalgia, pelvic floor disorder. Um, and then we can move to gastrointestinal, like irritable bowel syndrome, or even inflammatory bowel disease like Crohn's or ulcerative colitis. You can have diverticular disease, and then you have bladder, so interstitial cystitis, UTI, and then we have the gynecologic things like endometriosis, scar tissue in the pelvic area, cervicitis, vaginitis, PID, chronic PID. Also things like appendicitis, mesenteric lymphadenitis. I think that's all I can come up with right now.
Okay, and so when she comes in, well, I know what else before, so that's a good differential for that. When somebody comes in with the complaint of dyspareunia, tell me what's your part of what's going to be important on the history, of course, is if she complains of more introital dyspareunia or deep dyspareunia. So what if she says she has introital dyspareunia? What would you be thinking about with that?
I would be thinking about vaginismus, for example, or any infections, chlamydial infection, or yeast infection, for example, contact dermatitis, any sort of skin inflammatory conditions, autoimmune. Probably that would be where I would start.
Okay, and what about deep? If she complains with deep penetration, what would you more be thinking about?
I would be certainly worried about endometriosis, adenomyosis, scar tissue. Again, there's non-gynecologic issues that could cause pain with deep penetration. You could be coming from the adnexa, you could have an adnexal tumor, torsion. You could have, inflammation in the bowel, whether that's diverticular disease or appendicitis or anything like that.
Okay, so tell me, so she comes in, you're going to take her history, and then you're going to do a physical exam to see if you can reproduce or at least localize where she's feeling the pain. Tell me how you're going to do the physical exam.
Okay, I would make sure, I would first ask the patient if she has any pain at all first. I would start with a general physical exam, including vitals and a lung exam as well as an abdominal exam. I would make sure there's no abdominal pain anywhere. And then I would move to a pelvic exam. First, I would get a Q-tip and see if there's any pain on touch of anywhere on the vulva, and if it's localized or generalized on the vulva. And then I would do a pelvic floor muscle exam, seeing if there's any pelvic floor dysfunction. And then I would see if there's pain reproducible on manipulation of the cervix or palpation of the uterus or adnexa.
Okay, so on her, when you did the physical exam, did you find anything that helped direct your therapy? Because I see you sent her to pelvic floor physical therapy and you actually decided to try her on medical management with Elagolix. So what was it that you found on physical exam that made you want to do that?
So this patient has already been trialed on combined oral contraceptives continuous, and on physical exam she had a lot of tightness on the pelvic floor muscles, but I also felt that on a rectovaginal exam there was scar tissue, or at least uterosacral ligaments were scarred, and there was significant pain with manipulation of the cervix and movement of the uterus. So I felt it was probably a combination of endometriosis and pelvic floor dysfunction, but I think it was quite multifactorial, and a lot of these women do have more than one issue contributing to their chronic pelvic pain.
Agree. Now, what dose of Elagolix did you give her?
I gave her the 200 milligrams.
And why did you choose that dose?
That's the dose for pain management with endometriosis.
Then what's the 150 dose for?
It could be used for abnormal uterine bleeding, or if a longer duration of management is also desired.
All right, and so how long can she take that 200 dose?
6 months.
Okay, yeah. My understanding is that with the Elagolix, especially if they have significant dyspareunia that's due to endometriosis, that's the big indication for the 200 milligram dose. What can be side effects that she can get?
So sort of menopausal symptoms, hot flushes, you can get vaginal dryness, you can get dyspareunia from the vaginal atrophy. Those would be the main ones. But you can also, with long use, you can get impacts on bone health, and that's why the 6-month treatment is recommended.
Okay, so now let's go with, so the 200 milligram dose, you do it twice a day, you do it for 6 months versus the 150 that you can take for up to 2 years. Now, what about, does it work as a contraceptive?
No, it does not work as a contraceptive.
Okay, so do you know what this patient used for contraception?
So I recommended, well, at the time when we started the Elagolix, she was not sexually active because of the pain, but we discussed that I would recommend a Mirena IUD.
Okay,
And
so that should she knows that that she needs contraception and
yes.
okay, all right, perfect. I'm trying to think what else, because with the 150 milligram dose, they didn't find relief of dyspareunia in that dose, but with the higher dose for a shorter duration, that was, when they did their trials and stuff, so that would make sense for that. And I guess the big thing, of course, is that we have to make sure the patients know it does not work as a contraceptive, and we would not want them to get pregnant when they were on that. And then pelvic floor physical therapy, absolutely. Patients can have multiple causes for their chronic pelvic pain. We should never just stop at one. And the amount of secondary pelvic floor dysfunction from anybody who's been in pain for a long time, if you look for it, you'll be stunned how much you will find it. And we are lucky we've got physical therapists who will manage that. I'm trying to think if anything else. No, I like the way you went through chronic pelvic pain. You talk about, I think about gynecologic and non-gynecologic. That's especially when there's huge differentials. What's most important is not that you remember every single every single thing, but that you can let the examiner know that you understand the big picture. So when you can say something like, I think about gynecologic problems or causes and non-gynecologic causes. And then of the non-gynecologic, I'm thinking about, and this is exactly what you did, Anzi. I'm thinking about GI, GU, musculoskeletal, and psych. And then you can go back and give a couple of examples of each, but at least it shows to the examiner that you get the big picture, because it's way more confusing if they go, well, what can cause chronic pelvic pain? And you're like, well, it could be painful bladder syndrome, and endometriosis, and oh yeah, chronic constipation, and I guess it could be pelvic floor. It sounds it's all true, but it sounds much more disorganized. And if you can almost think when there's a big differential that you can almost outline it, and then go back and fill in the blanks, it just is a nice way to answer what can be a fairly complicated question. Just like with the OB case, if they asked you, so how do you counsel somebody who comes in with chronic hypertension of the risks of chronic hypertension in pregnancy? I want you to say something like, I always think of it in terms of maternal risks and fetal risks, and do that for anything. And then you can go back and enlist it, and it will also help to organize you that way. All right.
Wonderful. Thank you. I have one more question. When you asked about physical exam, was that sufficient or should I go into any more detail?
Yeah, so here's the big thing. The main thing is, of course, that we don't just focus on the pelvis, on the gynecologic part. I mean, some of the, you definitely are going to do an abdominal wall exam. You're going to be looking for any evidence of trigger points, like in myofascial syndrome. Then when you do externally, you're right, you're going to be doing the Q-tip. You're going to be looking for any evidence of a vulvodynia or vestibulodynia, whatever the heck we're supposed to call it now. Back in my days, we called it vulvar vestibulitis, and that just rolls off my tongue better, but whatever. You're going to do that. Then you're going to do a one-finger digital exam before you put in the speculum, where you're going to push on the perineal body, looking for any evidence of vaginismus. Then you're going to do that one finger circumferentially around the vagina, looking for any pelvic floor dysfunction. If the bladder's tender, it's going to, or causes pain, that's going to make you think more of a painful bladder syndrome, interstitial cystitis. Then you can do your bimanual exam and then look for everything. And then, of course, with the speculum exam, you're looking for cervicitis, etc. But you're going to do a one-finger vaginal exam before you do a bimanual and before you put in the speculum. So, good.
Thank you.
Thank you. All right, so let's see. Let's get Daniela. Hey, Daniela, how are you?
I'm good. How are you?
I'm just groovy. Let's see here. So is OB okay for you? We've done a GYN in the office.
Yeah.
All righty, we'll try to keep it real here and kind of keep it jumping around. Do you have any particularly gruesome case that you'd like to share with us all?
I mean, I have a cystotomy.
All right, it was
It's at the end.
okay. It's not your repeat, like a repeat C-section or something. It's way so it's your little complications. All right.
It's the only complication I have on there, so I figure it's probably worth trying.
Yeah, let's go ahead and do it. So you have a 30-year-old G1P0 who was at 40 weeks 1 day, who you did elective induction of labor. Okay, so let's just stop right there. Tell me why you induced her.
So this is actually one of my partner's patients, and so she had that prior discussion with the patient about potentially undergoing an elective induction of labor after 39 weeks. She declined at 39 weeks, but then when she got to 40 weeks, she opted for an elective induction of labor.
Okay, and so she got, oh, that's for her C-section, her antibiotics. Okay, so anyway, so induction of labor was performed and the patient developed a first stage arrest. Tell me how you define that.
So the patient had gone all the way to 6 centimeters with artificial rupture membrane. She did have an IUPC placed that demonstrated adequate uterine contractions over the course of 4 hours and got to 8 centimeters, but then didn't progress further after that.
Okay, and so then, so she got to 6 centimeters, then she got to 8 centimeters, and then what? Just stuck at 8?
Correct. With
Okay, and so
adequate uterine contractions.
okay, and so just go ahead and review for everyone how you calculate if contractions are adequate.
So basically, you look at the uterine contractions over a 10-minute period, and you should have MVUs greater or equal to 200 Montevideo units.
And how do you measure those? How do you measure a MVU?
It's you look at the bottom of the fetal heart rate tracing, and typically the IUPC is zeroed out, and then you count up, and it's increments, I believe, of 10. And you count from the baseline up to the nadir of the contraction. You add those up over 10 minutes.
Okay, so now she's got a first stage arrest, so you're going to do a C-section. You give her pre-op antibiotics, and tell me, when did this cystotomy occur?
So the cystotomy occurred while attempting to enter the peritoneum. So typically when I enter the peritoneum, I do this bluntly. I attempted bluntly, but was unable to. So then I proceeded with attempting to use a hemostat to kind of dissect through the peritoneum. Unfortunately, that still didn't work, and I was high where we should enter higher up. And since that didn't work either, then I did actually tent up the peritoneum and incise with Metzenbaum scissors, and that was when the bladder injury occurred.
Okay, and so in hindsight, what do you think was happening? Like, why you had such trouble getting in?
So it wasn't necessarily found out until afterwards when urology came in and the bladder was repaired and we were attempting to backfill the bladder, but it was actually found that the catheter was kinked. So even when I made the cystotomy, about 250 to 300 cc's of urine came out. So I think it was secondary to that the bladder just wasn't draining. So it was higher in the pelvis than what it would have been if it had been draining.
Well, because that's what I was saying. Something's wrong. That bladder is not deflated or whatever, because for it to be there and for you to, not be able to get it. So unfortunately, you're right. It must not have been adequately draining the bladder. All right. So, but when you were tenting this up, so this wasn't, you couldn't see through it, right? So why would you have thought that her peritoneum would be scarred when this was her first ever delivery?
I didn't, but I didn't have a good answer for it. And either way, even I was high up, the bladder shouldn't have theoretically been there.
Gotcha. All right, good. So how big was this cystotomy that you made?
It was about 2 centimeters.
Okay, and so you called in urology, and tell me what they did.
So when the urologist came in, they examined the cystotomy and then they repaired it in a 2-layer closure.
What sutures did they use and how did they close it?
It was closed with 3-0 Vicryl and running with the submucosa and then with the mucosa and submucosa and then the outer serosa.
Okay, and so then how long are they going to want the Foley left in place?
So Foley's typically left in for 7 days and typically not removed until you've done a cystogram to assure that the bladder is healed before removing it.
Okay, after they repaired the bladder, did they do a cystoscopy?
We did not cystoscopy, but we did backfill the bladder. We had sterile milk and made sure that it was a watertight seal.
Okay, let me think, what else could I
And it
ask?
was the dome of the bladder.
Okay, that was good. Thank you for that. I was like, I know there's something else I should ask. Yeah, and what's the significance of that? That it's in the dome. Why did you tell me that?
Because bladder, well, first of all, bladder dome injuries typically heal pretty well, but if it was lower down and you were worried about being near the trigone, then you're in the vicinity of where, the ureter is and things like that, in which case you would likely opt for a cystoscopy in that situation.
Yep, yep, because the ureter's there and we need to make sure in the repair we're not kinking the ureters. All right, good. So now I guess I'm just going to ask you, what would you say, Daniela, if they asked you, now that that's happened to you once, looking back with hindsight, knowing what you know now, do you recognize when things just didn't seem the way they should have been? If something like that occurred again, would you handle it any differently?
I think in that situation, because it's happened to me before, I would likely have a little bit more patience and try to investigate a little bit further, like make sure that, the Foley is actually draining, which a nurse could easily, who's in the OR, look at for me. Although in this situation, there was actually urine in the Foley. So I don't know if that would have 100% ruled that out. But I do know, again, it's a primary C-section, so the tissue in that area should not be as thick. So I'd likely try to go a little bit higher and find that tissue where it's a lot thinner for me to bluntly dissect through.
Yeah, and you can just say, now that that's happened, that's what I would say. Now that that's happened, I have a better, I would have maybe stopped a little bit more, thought. I know now that even though a Foley has urine in it, doesn't mean that hasn't kinked after that urine, got in there and it got kinked afterwards. And I would have had the nurse evaluate the Foley and blah, blah, blah. Just say, like, in the future, if you came across the same thing, you're having trouble entering the peritoneum, you're going to maybe take a step back and think for a minute, okay, what else do I need to check? Okay, nurse, can you check the Foley, tug on it a little bit, make sure that nothing's kinked, it's adequately draining, you know what I mean? Stuff like that. So, when all of us have complications that occur. And basically the biggest thing is like, so if you were in this situation again, what would you maybe do differently? And I think that's exactly right. So good. Thank you for sharing that with us. Any questions I'll ask you, did the radiologist, did the urologist recommend the patient be on antibiotics at all with that Foley in place?
So we did, I asked as a courtesy because I've heard different, I know the data says that you don't actually need to provide them outpatient antibiotics. This urologist said it was fine to give her antibiotics while she had the Foley in place.
Okay, so what did you give her? Macrobid?
We gave her Keflex only because of the fact that Macrobid she had just delivered. And so we went with Keflex.
Okay. All right. Good. All right. So yeah. So she was done an antibiotic, and I'm with you. They're like, you don't have to, but a lot of people do, and I was just curious. All right. Thank you.
Thank you.
Let's get Elizabeth next. Hey,
Hi,
Elizabeth, how you doing?
I'm doing well, thank you.
All right, so let's see. And are you a generalist?
Yes, I am.
Okay, GYN or office?
I know this is, we just did OB, but I have a case that I'd really like to go over.
Love it. All right, that's what we're here for. Okay, tell me where I need to go.
It's case number 101. Yes, it's a lot of OB.
Yeah, right there. Here's the problem. 25 pages worth, right?
Yes, it's a lot of OB.
Okay, all right. So let's take a look at this. Why don't you present this patient to us?
So this patient is a 32-year-old G2P1 who came to me. Her initial prenatal care, she did say that she was a diabetic on metformin. She was a chronic hypertensive that I started her on labetalol. And her initial prenatal course, she came to her first few visits and then she missed several visits. And then when I saw her back again, she explained that she had a very difficult social situation and had difficulty with transportation. And I had also referred her to MFM for co-management, and she said that she was not able to do that either because of the distance for the travel. So it was a complicated patient, and what is concerning to me is that when she became more consistent with her care was in her third trimester. And she did miss her AFP screening, which would have been the time potentially when we might have noted an omphalocele. And that's what has me, there's two things about this case that have me concerned, is that it was not detected either on her anatomy scan or in her growth scan. It was a small omphalocele that was detected after birth, about 12 hours later before the baby was transported. And then the other thing about it is that because this patient's diabetes was becoming a little more difficult to control, as well as her high blood pressures, I was anticipating a delivery at 36 weeks. And I discussed with her the option of antenatal steroids, which I realize that those patients were excluded from the study for late preterm steroids. So, but I counseled her that her blood sugars could potentially go up with the steroid use. And we discussed increasing her basal insulin dose and for closer monitoring to call in her sugars. So that's my concern, is that
Okay,
maybe I should not have done that.
okay. So, all right. So let's talk about, so first of all, with AFP screening, at what gestational age do we typically do that?
That
What's our
would
window?
the ideal time is between 16 to 18 weeks, but you
Okay,
can do it between 15 to 22.
okay. And then, with it being, now the anatomy scan, with it not being detected on the anatomy scan, that's not on you. You didn't do the anatomy scan, right?
Correct, I did not. And it was done a little later. I believe it was not done at the ideal time because she had missed the window, but we did try to perform it a little bit later. I want to say it was at like a 26-week scan.
Okay. All right, so here's, if they asked you about this, you could say this patient was a very complicated patient. Not only did she have type 2 diabetes requiring frequent insulin adjustments and chronic hypertension that had some difficulty controlling. The patient had a very difficult social situation and she missed multiple antenatal visits. Because of that, she missed her window for AFP screening and her when she got her anatomy scan, it was actually done at 26 weeks, and this small omphalocele was not detected. And because she didn't even, she missed all the antenatal or prenatal visits where she would have been in the window for her maternal serum AFP, it was never done. Okay, I mean, you can't help that. You did do an NIPT, so let's talk about omphaloceles. You've got gastroschisis and omphalocele. What's the difference?
So a gastroschisis is typically to the right of the umbilicus, and it is a herniation of the abdominal contents into the amniotic fluid without a membrane covering. It is, and whereas an omphalocele is typically at the umbilicus with a covering of the membrane. Omphaloceles are also correlated with other anomalies such as, I believe it is Beck, oh, I'm so sorry, Beckwith-Whittiam syndrome, as well as other aneuploidies. Gastroschisis is not associated with aneuploidy. However, it can be associated with congenital anomalies of the bowel and the renal system.
Okay, so yeah, so and you did do an NIPT that was negative, and it as part of fetal development, doesn't everybody get an omphalocele at a certain point in time?
Yes, ma'am. That is typically before 12 weeks.
Correct. Okay, yeah. So that's kind of weird, but that kind of occurs like in that 8 to 10 week span, and then it resolves. But the omphalocele, of course, that persists. If you had, so let's do this. If this had been, if she had had an AFP that was abnormal, if her anatomy scan at 18 to 20 weeks had shown an omphalocele, what would you have done different?
I think if I had been able to potentially show that there was a congenital anomaly, like an abdominal wall defect, I honestly don't know that I could have done anything other than potentially get her reinforce the importance of being seen by maternal fetal medicine to assess whether delivery would need to be at a tertiary center because of potentially the size of the omphalocele.
Okay. All right. I can see that, because I was going to say, what would it really have changed in your management? And that's what it would have changed. Had it been identified, you could have, you had already recommended she go to MFM. And again, she didn't do it, but maybe it would help to emphasize the need for that. All right. So that's that. With regards to the antenatal steroids, yeah, so for sure, up to 34 weeks, somebody with diabetes, gestational diabetes, you'd give antenatal steroids. The whole big question is, do we, if they've never had them before, and if we're going to give a dose, should we give it into the patients who have pre-gestational or even gestational diabetes, with the thought that it could make their blood sugars go higher? And so I've seen, because I review case lists of you guys, the candidates from all over the country, I've seen different recommendations where some MFMs tell them don't do it, and I've also seen where MFMs have also said it's fine to do it. So in this case, you could just say you were anticipating delivery at 36 weeks with all of her obesity, chronic hypertension, her type 2 diabetes, that you discussed with her that the antenatal steroids can definitely increase her blood sugar, and you accounted for that, because here's the thing, you gave it to her when, if she was going to be monitoring at home, how far in advance to this induction of labor did you do antenatal steroids?
It was done 6 days prior.
Okay, so there's a good example. It's a lot different than when they come in with preterm labor at 36 and 3, and you're given the first dose while they're laboring. Do you see what I'm saying? Then you're going to have the potential to have high glucose levels, then the baby be born, and then it go hypoglycemic, etc. You started it far enough in advance. You basically started it at 35 weeks and something, so that it would have had an opportunity. You know what I'm saying? If her blood sugars even did go up, they're going to come back down again before you
Yeah.
induced her. So that would be how you would discuss that.
Okay. Okay. Yeah, she received them actually 6 days prior, because I went back to check and confirm that and then came back for her repeat dose 5 days prior. So
Well, but wait, wouldn't you have given a dose and then 24 hours given the second dose?
right. I guess I was trying to work backwards. She got it on
Oh, okay.
March 9th and 10th, but didn't deliver until the 15th.
Okay, yeah, I'm good with that. Does that make sense, that why that's different than giving it to somebody right when they show up in preterm labor and her blood sugar could be high and you haven't controlled it, and then the baby's exposed to that hyperglycemia while it's laboring and could have a significant hypoglycemia afterwards?
Yes, ma'am. Thank you very much. I appreciate that.
Okay, good. Yeah, so yeah, omphalocele is associated with aneuploidy and other congenital anomalies. Now, this is going to be funny, but this is how I remember things sometime. Gastroschisis starts with a G. So I go gastroschisis, good. Omphalocele, oh, that's bad. Okay, so that's how, for those of you out there, you've got it down, Elizabeth, because you've got them on your case list. But that's how you can kind of remember that omphalocele is the one that's a little bit more ominous and can be a higher risk of aneuploidy and other congenital. But how did the baby do?
Baby actually did well. They discovered once the baby was transferred that they confirmed the omphalocele on a cross-lateral scan. They found bowel gas in the umbilicus, and it was repaired. And then they did a microarray, which came back as negative, but the baby did have a duplicated renal system.
Interesting. Now, here's one of the questions they could ask you. In somebody who has type 2 diabetes, especially if their A1C levels were significantly elevated during the first trimester, what are some of the anomalies we can see when there is hyperglycemia during the period of organogenesis?
The ones that you would look for would be cardiac anomalies, an ASD, a VSD, transposition of the vessels, also sacral agenesis, and I know I'm missing one.
Is it limbs?
Right? Is it
Like
skeletal? Yes, skeletal. Is it
with some, I think if there's some limb things. So, but yes, but for sure the heart and the spinal, the
and then
sacral agenesis. Yeah, go ahead.
right, and then also neural tube defects as well.
Yep. Yep.
Okay.
So the neural tube defects, the cardiac, the sacral agenesis, and I think limbs, something with the limbs. All right, good. All right, well, that was a great case, and it covered a lot of different topics, including that omphalocele is normal in the first trimester. Okay, great. Thank you, Elizabeth.
Thank you.
All right, so let's see. Let's get Emily. Yep, there you go. Now, yep, you just unmuted. How you doing?
Perfect. Not too bad. I'm going to jump downstairs because it's storming.
Oh, where are you?
New York.
Oh, you just got a rainstorm coming through?
Yeah.
Okay.
Out of nowhere. Yeah. Like, hope I don't lose power, but we're good.
Oh, okay. So do you want office or GYN?
Let's do GYN.
Okay, all right. Do you have any particularly interesting case?
Um, I have longer lists as well, just from a busy academic year, but nothing specific that I can think of.
All right, so then let me just kind of take a look through here. Let me kind of try to go toward the end. Let's look at patient 94. So she's a
Okay.
45-year-old G0P0 with abnormal uterine bleeding, and an ultrasound reveals a huge submucosal myoma. She has
Yep.
acute blood loss anemia, and then let's just add to it that she's had a PE and is on chronic anticoagulation. Do you recall why she had a PE, and like, has she had a thrombophilia workup?
Yeah, she was a really interesting case. She um, had presented to the ED just with dyspnea, was a healthy patient kind of leading into that, was found to have a huge saddle pulmonary embolus and actually got sent from our area. I was at a different practice to a different state to get a endarterectomy. She has seen multiple hematologists, both at our center and at the other center, has had full thrombophilia workup that was all negative. No reason that they could find for why she developed this.
How bizarre. Wasn't on
Yeah,
estrogen containing OCPs,
she was
hadn't
not.
hadn't been on a round the world plane trip, sitting
Nope,
in
wasn't
coach or
non-smoker.
anything. Oh
Yeah,
my
BMI
gosh.
26. Yeah,
Oh wow.
healthy. Like I said, she walked into an emergency room and she actually went to urgent care and they sent her home. And then she still wasn't feeling well, so then she went to emergency room. It's kind of quite a dramatic presentation. So
Yeah,
she's fortunate she went to the emergency room, in all honesty.
yep. So with her anticoagulation, what is she on? Like,
She was on a Pixaban. She had developed HIT when she was hospitalized as part of the endarterectomy, so she could not have any heparin-containing products.
holy cow. So tell me, what
Mhm.
is HIT?
So HIT is heparin-induced thrombocytopenia. It is when patients are on chronic heparin use, they can, from my understanding, develop kind of antibodies that then kind of attack their platelets um, and then develop thrombocytopenia as a result.
Yeah, and it's much more common with unfractionated heparin than Lovenox. It's like a couple percentage of people can get it, where it's like less than 1% with Lovenox. But yep, it can happen, and it can be, it's definitely a problem. So she was on another anticoagulation. So anyway, you do an ultrasound. She's got this big submucous myoma. Her
Mhm.
endometrial biopsy was benign, but you did try her on some medical management. And what was that medical management that you tried?
I did. So in her case, obviously, estrogen-containing products were contraindicated, and so we tried oral progesterone, and she continued to. She bled every day that I treated her for, I think it was 2 months.
How low was her hemoglobin? Because I see that you did have to give her blood replacement before you did her hysterectomy.
Yeah, she had a hemoglobin of 8, despite the kind of medical management. So I transfused her up to a hemoglobin of 10, and then and then I did her surgery.
And so did you do it like, okay, you failed medical management, I'm putting you in the hospital, I'm giving you blood and then operating? I mean, was this all one visit, or do you know what I'm saying? Did you do the blood?
Yeah, good question. I transfused her as an outpatient, but I transfused her on, I think it was a Friday, and then I operated on Tuesday.
Okay. When, I guess, did you ever consider like putting her on something like a Depo-Lupron to just temporarily stop bleeding and let her build her own blood up?
Yeah, we talked about this with her hematologist and pulmonologist, and you know, despite knowing that it didn't contain kind of estrogen and hormones, they were very nervous with her history that kind of any medications would kind of increase her risk for a clot, and they recommended against it.
Okay, all right. So now tell me then how you managed her anticoagulation in order for her to have her hysterectomy.
Yeah, with her, in consultation with her pulmonologist and hematologist, we decided to hold her medication 48 hours prior to surgery, and then we restarted it 24 hours after the surgery. I kept her inpatient overnight, checked her blood counts in the morning, and then knowing they were stable, restarted her at that point.
And so what were you able to do to try to reduce her risk of getting a DVT, you know, like
Yeah,
intraoperatively, and you know what I'm
yeah.
asking you.
I had SCDs on. We did, you know, early mobilization post-op, so that she was walking around. But
Yeah,
unfortunately, I could not give her heparin. Normally, I
yeah,
would give
that's,
heparin,
I was gonna
you know,
say, yeah, because you
but
can't give her
unfortunately, in this,
heparin because of HIT, right?
yep, yep,
So you
we're a
you
little
stopped
mess.
the oral medication about 48 hours before, made
Hmm.
sure she had pneumatic compression devices on before induction of anesthesia through the surgery, all the time she was in bed, early ambulation, and then it was restarted, what, 48 hours after?
24.
24
Yep.
after. Okay. All
Yep. I
right.
checked her hemoglobin the next morning. It was appropriate, inappropriate kind of drop. Her vitals were all normal, no signs of bleeding, and so we restarted it then.
Okay. And then so you did a total laparoscopic hysterectomy on her. Her uterus was a pretty good size for somebody who's never had any kids. Because what should a uterus weigh?
A uterus should weigh around, isn't it like 80 to 100 grams?
Maybe even like 60 to 80, especially in somebody
60 to
who
80.
hasn't had any kids. Maybe up to 100 if she's had kids, but more like 60 to 80-ish. So yeah, it was,
Yeah.
that
Yeah.
fibroid
That
was,
that fibroid. Yeah.
yeah, causing some issues. And then you did also see some endometriosis. I know you noted it on the pathologist says on this uterine serosa and fallopian
Yeah.
tube, but you see much in the peritoneal cavity?
Yeah. So this was a surprising one, given that she did not have any pain um, going into the surgery, but she had, especially on that left side, nearly a frozen pelvis. I could not identify definitively or safely a left fallopian tube because the whole left adnexa was just adherent to the pelvic side wall and to the uterus. I spent probably 45 minutes to an hour just with kind of like, you know, dissection in order to perform even the hysterectomy. And so that's why I only did a right salpingectomy on this case, actually, because I could
Well,
not safely. Yeah. And
well,
then it's a balance of operative time with this case.
yeah. Oh, yeah. Especially since she can't do anything but the pneumatic compression devices. All right.
Exactly.
Okay. Yeah. So anyway, now that you said that, I didn't actually notice it until you started talking. That yeah, you only took out her right tube, so you did as much excision and so how did you identify the ureter on the left
On the
when
left
you were?
side.
Because that's where everything was stuck.
Yeah. Um, I went back kind of up to the pelvic brim at the bifurcation of the iliac and was able to identify the ureter there and then trace it through.
Okay. All right. Good. And I bet she does fine and she's happy and she's not anemic anymore and has more energy.
Yeah, she had an outstanding recovery, actually, better than many of my patients who undergo hysterectomies. I saw her later that week in the office, and her blood counts were rising. We trended I followed her closely, so I trended her weekly through her 6-week visit, and you know, her levels normalized. She was feeling a lot better. I think she didn't realize how the endometriosis was probably playing a role because she was so focused on obviously all of the other major medical conditions she had, but she felt remarkably better after.
Well, that's fabulous. So not anemic can maybe help reduce some pain. Yeah, so that would be the main thing. And the reason I brought up this one too is because ACOG published a fairly recent practice bulletin on the prevention, I think it's the prevention and treatment of post-operative DVT. So I could totally see that being, since that's been recently published within the last 12 months, that would be something that even if they didn't ask you, for all of you guys on any of your GYN cases, they could be like, so what percentage of people would you think can get a post-op VTE, and what do you do to prevent it, and when do you give pharmacotherapy, when do you just do pneumatic compression devices, how do you determine that, etc. So that would be a good practice bulletin to review. And so thank you for sharing with us. And then especially with HIT and all that stuff, you're right, she's very interesting. So there's obviously something going on with her hematologically that we're just not smart enough to figure out yet. You know what I mean? That we, just like with all of these new genetic mutations, it's so much more than BRCA1 and BRCA2 now. And it's like with this type of stuff, we just aren't smart enough to figure it out yet. All right. Well, thank you, Emily.
Thanks.
I have nothing to add. You did a really nice job of how you presented her. And yeah, so she's an interesting case. Oh, really cystoscopy. Do you routinely do cystoscopy on all your? Okay.
Yeah, I do universal cystoscopy.
Okay, sounds good. And you could explain that why. How would you explain that to the examiner?
So with I perform universal cystoscopy because kind of early identification of any injury can decrease the morbidity. I'm able to call in and repair the injury at the time instead of kind of a delayed. I also practice at a teaching institution, and so it's important for me to teach how to perform a cystoscopy. It's an important skill for all OBGYNs to know how to do confidently.
Okay, sounds good. And if you're letting them do the case, you really got to make sure the ureter's okay. No, no, you don't have to say that, but
no, I don't say that, but yes, that is why.
Okay, all right. Thanks, Emily. All right, let's get Erica.
Hello.
Hey, Erica, how are you?
Good, how are you?
Good. Are you a generalist?
I was doing gyne only.
Okay.
I did a fellowship in pelvic surgery with a gyne component.
Okay. Okay, so do you have a preference of what case list you would like to do?
I've done office practice recently, so I suppose we could do OB.
All right, let's do that.
Okay.
So let me just see here. Let's just look at patient 16.
Okay.
So 27G1P0, you made the diagnosis of fetal growth restriction. How did you make that diagnosis?
It's an estimated fetal weight less than the 10th percentile or an abdominal circumference less than the 10th percentile.
And how would you have diagnosed that? I mean, I know the definition. I mean, what made you, when did you detect it?
On a growth ultrasound. And I believe that was obtained due to a inappropriate size less than dates measurement in the clinic.
Okay, and so then once you do that and you see either an abdominal circumference less than 10 percentile or an estimated fetal weight less than 10 percentile, so now you've got a diagnosis of fetal growth restriction. How are you going to determine if this is truly just a constitutionally small infant or it's truly growth restricted?
Yeah, so with all patients in the outpatient setting, we are following their fundal heights throughout the pregnancy. So if we see that they are not following the same trajectory that could suggest growth restriction more so than somebody who's always been, 3 or 4 centimeters behind. Having normal Dopplers is reassuring that I mean, you can have fetal growth restriction with normal Dopplers, but that's another thing that can contribute to your degree of suspicion of a constitutionally small fetus versus fetal growth restriction. Also, if the growth restriction is symmetric, or well, if the smaller percentile size is symmetric for head circumference and abdominal circumference, that can sometimes be seen more with constitutionally small infants or fetus compared to more discordance with fetal growth restriction.
All right, let's pretend that you detected this growth restriction at approximately 34 weeks gestation. Tell me what sort of what is the surveillance that you will be doing, how often, and how often you will be doing it?
Yes, so she would have antenatal surveillance and weekly Dopplers. Our typical surveillance protocol was doing biweekly NSTs. The other option, you could do a modified BPP weekly or a BPP weekly.
What about growth ultrasounds? Are you going to do those?
Yes, growth ultrasounds would be every 3 weeks.
Okay, so we're going to get the growth ultrasounds every 3 weeks. Obviously, if it was a constitutionally small infant, it will be still continuing to grow and stay on the growth curve. Whereas if it's growth restricted, it's going to, even though it started off small, it's going to not be growing it'll be falling off the curve. All right, so we got that. Let's talk about fluid. How does why is the development of oligohydramnios somewhat ominous in the face of growth restriction?
The development of oligohydramnios is a sign of it reflects placental function. So if you are having oligohydramnios, that's suggesting that the growth restriction or the poor perfusion or placental supply that the fetus is getting is worse.
Yeah, because where does the amniotic fluid come from?
Amniotic fluid is, it is, of course, the origin is from maternal serum supply. It comes through the placenta and is always processed, like the baby or the fetus swallows and it goes through its system and it urinates, and that's the kind of cycle the amniotic fluid takes.
Okay. All right, and so let me ask you another question. Let's talk about the umbilical artery Dopplers. Why do we do those? Well, I guess not why do we do these, but what is it in the findings that will help us with our management? So tell me what would be reassuring, tell me what's going to be worrisome, and you're going to want that baby delivered sooner.
So normal Dopplers are reassuring that there's kind of normal perfusion and cardiac function. And then if you have elevated S/D ratio, that is kind of the first sign that flow is compromised. If you have absent flow, that is a kind of worsening of that state. And if you have reversed flow, that is the most ominous of the Dopplers.
Okay, what are some different causes of fetal growth restriction?
Causes and risk factors include smoking, hypertensive disorders, particularly chronic hypertension, also maybe an earlier onset gestational hypertension, preeclampsia. Any infectious cause, so the torch infections are associated with fetal growth restriction. Early so diabetes prior to pregnancy can actually cause fetal growth restriction. And those are the initial things I think of.
Okay, and then let's see here. All right, so let me just kind of, a good way, again, so when there's so many different issues that it can be, a good way to organize it is if somebody said to you, and this, I'm saying this for everybody. So if somebody says, you know, what increases the risk of growth restrictions? Hey, I think of it in terms of maternal causes, fetal causes, and placental causes. So again, that shows to the examiner that you get it. So of maternal causes, that would be like your,
I didn't think of congenital things.
right, then the
Yeah.
maternal causes, you're going to go into your smoking and your cocaine and, you know, chronic hypertension and pregestational diabetes and hypertensive disease of pregnancy. Of the fetal causes, you're going to go into your torch syndromes, congenital anomalies, and your ploidies. Placental causes, so it, you know, basically everything we just kind of discussed, especially the chronic illnesses in the mom, it all comes down to uteroplacental insufficiency, but there are some certain things associated that are truly placental issues that can be associated with growth restriction. Can you think of some of those examples?
Truly placental issues. I mean, I suppose a chronic abruption would.
Yeah, that would be a good one.
Everything that I think of with the placenta is actually maternal.
Okay, so let me just kind of, so like marginal cord insertion, velamentous cord insertion, circumvallate placenta, maybe even a 2-vessel cord, you know, that can be associated with anomalies and stuff. So those are just some things. So if you think of it in terms of maternal, fetal, and placental, that will help you to organize the differential. You did a nice job on the Dopplers of the abnormal ones and how that helps with the decreased amniotic fluid. You're right. It's telling us that the fetus is not being perfused. If we're not getting enough blood flow, through the placenta, then the kidneys aren't being perfused and the baby's not making as much urine, and it's just all a reflection of poor perfusion. So, good.
Yeah, I remember more how I explain it to patients than how I actually learned it in a book. So I probably should review that.
Okay, sounds good. But anyway, you did a nice job. Thank you.
Thank you.
Let's get Hannah. Hannah, you're going to be our last one for the night.
Okay.
All right, you're gonna take it, finish it up for us. So let me find you. Alrighty. So do you have a particular case or case list you'd like to do?
No, I do not. I think
All
would
right.
Office be next on our list?
Yeah, I think we're on Office, don't you?
I believe
Is that
so.
what you said? Yep, that's what I think too. Okay, so let me do this and let me just pull something funky out of here. I'm trying to come up with something that maybe we haven't touched on for a while. This one's interesting. This patient here, 28. Let's talk about this for a minute. Okay, looking at this patient, would you think this patient is a good candidate for endometrial ablation?
No, I would not.
Okay, good. I'm glad you said that. All right, so tell me why if you had been managing this patient and she was complaining of abnormal bleeding, of why you feel that an endometrial ablation would not have been ideal for this patient.
So for a patient with abnormal uterine bleeding, when she first presents, I would take a history, and if her history led me to be concerned about anovulatory cycles, I would be concerned about potential risks of endometrial hyperplasia and the risk of at age 35 of being unable to evaluate her endometrial cavity, and then also addressing the root cause of her anovulatory cycles, which would not be fully addressed by an endometrial ablation.
100% I agree with you. She would have been, if you were managing this patient with abnormal bleeding, what would have been, with this, looking at her whole picture, tell me what your recommendations would have been.
So my recommendations would have been based on the etiology of her abnormal uterine bleeding and based on her history, and ruling out alternative causes would have led me to a diagnosis of PCOS. Then I would have discussed with her ovulatory regulation and could have discussed at that time combined hormonal contraception, as well as endometrial protection with a Mirena IUD.
Okay, and so with this patient, when she comes in, she's complaining of hirsutism. Do you know, is she using anything for contraception?
I believe that she was not sexually, that she stated that she was not sexually active and she declined contraception.
Okay. Okay. And so let's talk about that. Why would that, okay, we know with an ablation, it doesn't work as contraception. So they're supposed to be on a contraceptive. So if she's not sexually active, okay, fine. So that takes care of the ablation aspect. But why am I asking that? Why, if you're going to put someone on spironolactone, would you want to make sure that they were on effective contraception?
Spironolactone is teratogenic.
Why? What does it do?
Spironolactone is an androgen inhibitor, and so it can prevent abnormal development of a male fetus.
Okay, and so with her hirsutism, so you did do labs, she did have elevated triglycerides, elevated LDLs, but you also said hirsutism labs. What labs did you do?
For this patient, I did also consider non-classic congenital adrenal hyperplasia for her, and so I also did a 17 hydroxyprogesterone.
And what else? So, I mean, you said you did hirsutism lab, so all you did was a 17-OHP?
As well as a testosterone for her.
Okay, okay, so test. What about a DHEAS? What made you not want to check that?
Generally, my understanding of DHEAS is that it is most likely to be positive when a patient has virilizing symptoms, so extreme hirsutism or a deepening of their voice.
Okay, and then so you started her on spironolactone to help with her hirsutism. Why not OCPs?
She had previously been on OCPs before considering her ablation, and she stated that she had experienced prior weight gain as well as mood symptoms, and so she declined them.
Okay, let's see what else. If somebody came in, let's say she didn't have PCOS, let's just say you had a 22-year-old come in with the complaint of hirsutism. So let's say she's even having, well, let's not even talk about her cycles yet. Hirsutism, that's her main complaint. She's normal weight. What's the most common cause of hirsutism?
The most common cause of hirsutism in a 22-year-old. I'd have to get back to you on that.
Okay, so tell me how you would evaluate a 22-year-old with hirsutism.
I would start by taking a menstrual history and a past medical history for the patient, as well as a physical exam. And then I would, based on the physical exam, so if, for example, I saw other signs of hyperandrogenism, such as concern for hidradenitis suppurativa, I would discuss with the patient workup for elevated androgenicity with testosterone and potentially 17-OHP.
All right. You know what's the most common cause? Familial.
Okay.
So, and they really say up to 50% of the time, hirsutism, they'll tell you all the women in our family, we have mustaches or we have to bleach or stuff like that. So familial actually is the most common cause for hirsutism. And then you go into your PCOS would be the next one. Then you're going into your ovarian tumors, adrenal tumors, and maybe like ingestion of anabolic steroids or something like that. All right, so you put her on the spironolactone. She didn't want to do the OCP. She's not sexually active. So if they asked you, how does spironolactone work and what are common side effects, what would you say?
Spironolactone is an anti-androgen, though it works best with a secondary method such as an oral contraceptive in combination. And common side effects can be hypokalemia. Hyperkalemia.
Yeah, so it's kind of like aldosterone. It's like an aldosterone derivative, and it can cause hyperkalemia. And so I know theoretically drospirenone can also do the same thing. So I don't know that I've ever read if you can give drospirenone containing OCPs in spironolactone. You might not be able to because they both increase potassium. I don't know that I've ever thought about doing that, but that would be something. So yeah, so spironolactone, it actually works. It binds to the testosterone, actually the 5-DHT receptors on the hair follicles, and it actually blocks the active form of testosterone, the 5-DHT, on the hair follicles. And so that's why it helps with like oil production and acne and also hair production. So how do OCPs help with hirsutism?
They can help with hirsutism by increasing the sex hormone binding globulin.
Correct. And so what does that do?
So that would decrease the amount of free testosterone.
Okay, good. All right. Yeah, so that was like the main thing I looked at is like, okay, would you is that your preferred method of treatment for an ablation with a PCOSer? Yeah, because ACOG actually does say there are certain people who are non-ideal candidates. They don't say contraindications, but they certainly emphasize a non-ideal candidate would be somebody who's a chronic anovulator, because these are the patients that are at increased risk for endometrial hyperplasia, endometrial cancer. We have now really reduced our ability to be able to adequately evaluate her endometrium should AUB occur, and we have not corrected the underlying problem. So good. All right, any questions, Hannah?
Do you think that for a patient in this situation with a history of endometrial ablation, that it is potentially could be asked, like, how would you, anything specifically that you would do to monitor increased risk of hyperplasia, or
they might ask you that, but you could just tell her, you would say, this is my concern with regards to the endometrial ablation, that, no, I guess you would basically say, well, because here's the problem. What happens with PCOS? They tend to get oligomenorrhea, right? Well, and if they've got an ablation, they're like, oh, I'm happy, I don't have periods. So let me think of this.
I guess I was thinking she didn't present with any irregular bleeding, but that would, if she started to have bleeding, which is obviously could be common with an ablation, that would be my.
Yeah, that's what I was going to just say, the same thing. You would just have to counsel her that if she develops any type of bleeding that is irregular, you need to know about it.
Okay, thank you.
And that you would want to evaluate it. All right, good. All right, everyone, let's, it's already a little bit after 10, so we will call it a night. I will be back on Thursday with case list defense again. So, all right, everybody have a great weekend. Or a great week, I'm sorry, the weekend's over.